Hi, I'm Kathleen Hahn.
And I'm Nicole Ron.
We're pelvic health physical therapists at Mayo Clinic, Rochester, Minnesota, and two of the authors on this paper. This study included 75 volunteers who were in the acute setting each 0 to 5 days post-vaginal delivery. Each participant completed a single session, including bedside transabdominal ultrasound imaging during pelvic floor muscle contraction. First, verbal cueing alone was used with patient unable to visualize the ultrasound screen. This was followed by a pelvic floor muscle training session using transabdominal ultrasound imaging, coaching towards the bladder lift as a form of visual biofeedback for pelvic floor muscle training. Lastly, participants performed post-training pelvic floor contractions. We then compared vertical bladder excursion measurements during volitional pelvic floor contraction pre and post training between two groups, those with bladder descend and those with bladder ascend during baseline pelvic floor muscle contractions.
There was statistically significant improvements in mean vertical excursion of the bladder base post-training. But what we found particularly interesting is that there were greater improvements demonstrated by participants who began with negative or paradoxical bladder excursion at baseline testing. So participants that had the greatest challenge initially performing pelvic floor or Kegel contractions showed the greatest degree of progress. Here is a video of a participant with positive bladder base excursion. The ultrasound probe is in the horizontal plane. The bladder is full, and just inferior to the bladder, you're able to visualize the hyperechoic funnel of the pelvic floor muscles. As the participant volitionally or intentionally contracts her pelvic floor, you're able to see the base of the bladder rise. This particular participant had a 0.2 centimeter excursion in the positive or cranial direction. Next, you'll see a video demonstrating negative bladder excursion. Here you can visualize the base of the bladder moving caudally or inferiorly on the screen with her attempt at a pelvic floor muscle contraction. Participants with initial bladder excursion like this in the downward direction were less likely to have intact perineums and more likely to have suffered more advanced perineal trauma during their delivery. We'll put our ideas about this in the discussion paper of our session, but we wanted to propose a question to listeners. In our study, 30.7% of participants demonstrated bladder base descent during their initial attempts at pelvic floor muscle contractions with verbal instruction alone. So we wonder if pelvic floor muscle contraction effort results in bladder descent rather than ascent in some women. Are we doing greater harm than good when we verbally and indiscriminately prescribe Kegels or pelvic floor muscle contractions in the early postpartum phase, which is the standard of care at most institutions?
Overall, our study outcomes suggest that this transabdominal ultrasound imaging is a feasible tool to support learning correct pelvic floor muscle contraction in early postpartum populations. 100% of our participants found the tool satisfactory and helpful, which also underscores that women in this population are willing to engage in this kind of visual feedback immediately postpartum, and that it may be an alternate to verbal or written pelvic floor muscle instruction alone.
Thanks for listening. We hope you enjoy our full manuscript.